Functional movement is never isolated because it is produced by several muscles acting as prime movers, synergists, or stabilizers that coordinate together. When observing movement patterns, the clinician should focus not only on the strength of the movement, but also, and more importantly, on the sequencing and activation of all the synergists involved in the movement. Initiation of the movement is more important than the final phase or completion of the movement. Janda identifies 6 basic movement patterns that provide overall information about a particular patient's movement quality and control. Today, we're going to look at hip extension, cervical flexion, and push-ups. The basic guidelines that the patient should use, or the clinician should use, is the patient should disrobe as much as possible so the clinician may visualize all parts of the body. Second, the clinician should provide minimal verbal cues so that the patient's preferred movement pattern may be observed. The clinician should not touch the patient at all, as touch can be facilitatory. The patient should perform each movement slowly over 3 trials. Muscle or limb trembling during these tests is considered a positive finding, indicating a weakness or fatigue. The hip extension movement is analyzed clinically to determine the patient's preferred recruitment patterns. To perform this test, the patient lies prone with the arms at the sides and the feet hanging over the table to allow for neutral leg rotation. The patient's head should be placed in a neutral position as possible. The patient is asked to lift the legs slowly towards the ceiling. Janda suggests that a normal pattern of activation during prone hip extension is the hamstring, followed by the gluteus maximus, followed by the contralateral erector spinae, followed by the ipsilateral erector spinae. Positive findings during this test are associated with hypertrophy of the hamstrings and thoracolumbar extensors, as well as atrophy of the gluteus maximus during the postural analysis. Other things to look for, or key indicators, is decreased gluteus maximus bulk, increased hamstring bulk, observation of the spinal horizontal grooves or creases, anterior pelvic tilt, increased or asymmetrical paraspinal bulk, and decreased trailing limb posture as terminal stance during gait. During the trunk curl-up movement pattern test, the abdominal muscles contract and shorten, thus flexing the spine. During this phase, the heel should remain in contact with the table. In saying that, the patient can also perform the curl-up test with the examiner placing his hands underneath the patient's heels to detect any early loss of pressure. The trunk curl-up test estimates the interplay between the iliopsoas and the abdominal muscles. Things to look for are decreased abdominal tone, lateral grooves in the abdominal wall, and impaired respiration. The push-up test examines the quality of the dynamic scapular stabilization. When the patient performs the test properly, the scapula adducts and upwardly rotates as the trunk is lifted upward during the push-up. The lowering of the body from the maximum push-up position is more sensitive in detecting the excessive scapular rotation, elevation, tipping, winging, and adduction or abduction because of the eccentric loading on the muscles. The push-up test is performed with the patient lying in a prone position with the legs extended in a preparation for performing the push-up movement from the feet. The clinician should observe the following scapular and torso movements and note any deviations from the ideal push-up movement. Also, look for a forward head with protracted shoulders, increased internal rotation of the arms, nipples that face out superiorly and laterally in males, and scapula winged or tipping.